il est très important de rappeler que nous ne pouvons pas atteindre l'objectif zéro palu seul. Nous avons besoin d'un partenariat entre les acteurs, les décideurs et les chercheurs. Un partenariat entre les gouvernements, la société civile, les communautés touchées et même le secteur privé. Un partenariat entre les pays endémiques au paludisme et les pays donateurs. Donc il est vraiment temps que nous nous unissions pour mettre fin une fois pour toutes au paludisme.
Nous constatons dans nos pays que le paludisme, malgré les actions qu'on entreprend pour venir en bout de cette maladie, nous avons toujours des difficultés. D'où l'innovation en matière de la lutte contre le paludisme à travers la lutte antivectorielle qui permettra de s'attaquer aux moustiques et permettra de l'éradiquer, et ce à travers aussi la disponibilité de fonds en faveur de la recherche.
Nous sommes à une étape importante de la lutte contre le paludisme. Nous amorçons vers la fin du contrôle du paludisme. Nous allons vers l'élimination. C'est donc l'occasion, l'opportunité de tous ces acteurs et toutes ces parties prenantes d'aborder des stratégies innovantes qui mettent au centre les communautés.
I suggest key malaria messages to be taught in schools through health clubs to equip them with the information to help them prevent malaria before, during and after pregnancy.
Innover pour la santé, c'est accompagner et renforcer les organisations de la société civile dans la lutte contre le paludisme avec des outils du community-led monitoring pour mieux capter les besoins de leur population et savoir comment y répondre. Mobilisons-nous ensemble pour être innovants dans la lutte contre le paludisme et dans le renforcement du système de santé communautaire.
Il faut agir sur le volet prévention aujourd'hui parce que c'est un pan très important. Parce que pendant longtemps, nous nous sommes appesantis sur le volet prise en charge. Parce qu'on dit souvent que la prévention guérit à 90%. Donc aujourd'hui, j'exhorte nos gouvernements, j'exhorte les leaders d'opinion, j'exhorte les organisations de la société civile à se concentrer davantage sur le volet prévention.
Il y a le défi à relever, c'est que l'utilisation et la conservation des moustiquaires imprégnés distribués aux bénéficiaires. Là, il y a un défi à relever parce que nous avons constaté que souvent ces moustiquaires sont mal utilisés et mal conservés aussi.
Aujourd'hui, le défi qu'on a dans la lutte contre le paludisme, c'est l'utilisation des moustiquaires imprégnés. Donc, en termes de solutions, nous souhaitons une préférence nationale, acheter les moustiquaires locaux, et pour que le budget alloué aux moustiquaires soit reversé dans la communication, parce qu'il faut actuellement, là où nous en sommes, il faut beaucoup de communication pour accompagner les communautés à utiliser les mildas.
On observe ces 2 dernières années une augmentation du nombre de cas de paludisme alors qu'on avait bien maîtrisé la maladie. Donc pour éviter ce regain du paludisme, il faut accroître les interventions, notamment impliquer davantage les organisations de la société civile.
Avec la décision du Fonds mondial d'intégrer les OSC dans cette lutte, nous demandons que cette lutte soit faite avec un effort continuel de la part de tout le monde pour combattre la maladie qui est vraiment néfaste pour le pays.
Merci beaucoup. Bravo à toutes les organisations de Madagascar, du Sénégal et du Bénin qui ont partagé leur expérience sur la lutte contre le paludisme, mais surtout leurs recommandations. Vous avez entendu les organisations de la société civile pour améliorer la lutte et vraiment atteindre zéro palu. Elles aimeraient qu'il y ait plus de fonds alloués à la communication, aux actions communautaires qui vont permettre une meilleure utilisation des moustiquaires imprégnés. Et elles voudraient aussi, dans la déclaration de CS4ME que vous allez recevoir, elles voudraient aussi qu'on assure la collaboration effective entre les différents secteurs pour la lutte contre le paludisme, mais aussi l'intégration des besoins des populations, besoins spécifiques adaptés aux réponses spécifiques dans les nouveaux plans stratégiques. Et comme vous le savez, cette année, beaucoup de pays sont en train de terminer l'élaboration de leur nouveau plan stratégique de lutte contre le paludisme, mais aussi l'élaboration des notes conceptuelles paludisme Fonds mondial pour le cycle GC7. Donc, il est très important, cette année en tout cas, qui est une année cruciale pour la lutte contre le paludisme, qu'on s'assure qu'on puisse établir des systèmes de suivi communautaire dirigés par les communautés et la mise en place des communautés de vigilance pour garantir l'accès aux services de qualité pour la lutte contre le paludisme et aussi assurer que les agents de santé communautaire aient un statut qui soit acceptable et puissent aussi être en nombre suffisant pour pouvoir couvrir les besoins des populations clés. Donc, vous aurez l'occasion de découvrir ce que la société civile demande dans la déclaration qui va être publiée juste à la fin de ce webinaire. Et nous espérons pouvoir continuer à travailler avec toutes les parties prenantes pour pouvoir atteindre zéro palu. Donc, nous allons continuer notre webinaire avec la présentation et l'introduction d'une femme leader de la lutte contre le paludisme. Il s'agit de Dr. Corinne Karema. Dr. Corinne Karema is the former director of the National Malaria Control Program, NMCP, in Rwanda. Dr. Corinne Karema was the head of the malaria and other neglected tropical disease division in Rwanda at the Ministry of Health. She was also, during her time at the National Malaria Control Program, she led the development of key strategy, policy, and research, which has guided the implementation of evidence-based malaria interventions, including resulting in increased coverage in critical malaria control intervention with significant malaria morbidity and mortality reduction in Rwanda. So Dr. Corinne was also very involved in the Rollback Malaria Partnership to End Malaria. She was the co-chair of the Eastern Africa RBM Network Committee, and she was also a member of the diverse WHO Scientific and Advisory Committee of the Global Malaria Program. So Dr. Corinne is a PhD student at the Switch Tropical Public Health Institute at the University of Basel in Swaziland. And today she has had many roles, but she served as a team leader on the Global Fund Technical Panel Review between 2017 and 2021. And she was in charge of reviewing the country's allocation for malaria. She's also a member of the WHO Program Advisory Group of the new vaccine, RTSS malaria vaccine implementation. And Dr. Corinne had many roles, including now she's the interim CEO of the Rollback Malaria Partnership to End Malaria. So we are very pleased to have her with us and to listen to her message to civil society and partner on this World Malaria Day.
Bonjour à vous tous, je suis Dr. Corinne Karema, je suis la présidente déléguée générale par intérim du partenariat RBM pour en finir avec le paludisme et c'est un plaisir pour moi de participer au forum CS4ME de cette année. La collaboration et l'échange des connaissances sont essentiels, comme vous le savez, pour aider les pays du monde entier à atteindre notre objectif commun, qui est d'en finir avec le paludisme pour de bon. Et j'apprécie beaucoup des forums comme ceux-ci qui nous permettent de partager les progrès réalisés, les leçons apprises, les meilleures pratiques dans la lutte mondiale contre le paludisme. Et je profite de cette occasion tout d'abord pour remercier les acteurs de la société civile, membres de CS4ME, qui contribuent à la mission du partenariat mondial RBM à travers leur active participation dans ces comités et groupes de travail et autres actions clés. Comme vous le savez, la lutte contre le paludisme est un moment crucial et je me permets de dire quelques mots sur l'état actuel des choses. Depuis 2000, un partenariat mondial et des investissements soutenus ont transformé la lutte contre le paludisme en prévenant environ 2 milliards de cas de paludisme et en sauvant plus de 12 millions de vies et en mettant l'éradication à portée de main. Bien sûr, il y a des points positifs et des points négatifs. Donc, je vais commencer par les points positifs à célébrer. Vous avez probablement tous entendu l'excellente nouvelle cette semaine. Récemment, l'Azerbaïdjan et le Tadjikistan ont réussi à éliminer le paludisme. Avec chaque pays qui réussit à éliminer le paludisme, le monde fait un pas de plus vers l'élimination du paludisme une fois pour toutes. Et bien sûr, comme vous le savez, les pays travaillent sans relâche dans la lutte contre le paludisme et les investissements récents ont produit l'un des pipelines d'intervention antipaludique les plus solides depuis des décennies. Cependant, comme je l'ai dit, il y a des points négatifs. Donc, malgré les succès, nous avons encore beaucoup de travail à faire. On a des menaces biologiques émergentes qui réduisent l'efficacité des outils existants comme les moustiquaires imprégnés ou les médicaments où nous avons la résistance aux antipaludiques que nous utilisons aujourd'hui, ainsi que la résistance aux insecticides. En outre, la reconstitution des ressources du Fonds mondial de l'année dernière a été insuffisante pour maintenir l'élan de notre lutte contre le paludisme. Ensemble, les déficits de financement et les menaces biologiques émergentes préparent une tempête parfaite pour le paludisme si nous ne prenons aucune action. Et comme vous le savez, l'année passée, selon le rapport mondial de l'OMS pour le paludisme, on a eu environ plus de 500 000 décès par an dus au paludisme encore dans le monde et ceci, comme vous le savez, n'est pas acceptable. Pour atteindre zéro palu, nous devons innover, investir et mettre en œuvre. Nous avons besoin des outils plus performants et je salue l'arrivée de la nouvelle moustiquaire préqualifiée de l'OMS, les vaccins en cours de finalisation et la communauté scientifique qui s'attelle à innover. Investir, de nombreux progrès ont été réalisés dans la mobilisation des fonds. Je remercie également les pays donateurs du Fonds mondial, l'initiative présidentielle des États-Unis pour la lutte contre le paludisme PMI, la fondation de Bill et de Melinda Gates et nos pays africains qui investissent des ressources dans la lutte contre le paludisme. Mais nous avons toujours un gap. Près de 3,8 milliards de dollars sont à mobiliser chaque année pour la lutte contre le paludisme si nous devons atteindre nos objectifs de 2030. Alors, dans ce contexte, qu'est-ce que nous attendons de la société civile? Comme vous le savez tous, la société civile est au cœur de la réponse efficace et équitable à la lutte mondiale contre le paludisme. La société civile est la mieux placée pour autonomiser, impliquer et mobiliser les communautés touchées et à risque de paludisme, aider à atteindre les populations vulnérables, stigmatisées et autres difficiles à atteindre, mener un travail de plaidoyer critique et défendre ceux qui ne peuvent pas se défendre eux-mêmes. Et bien sûr, tenir aussi les gouvernements responsables de leur engagement. Il est essentiel que nous continuions à soutenir et à renforcer les OSC dans leur travail de lutte contre le paludisme. Et pour cela, je demande à la société civile de continuer à contribuer aux efforts de plaidoyer pour la mobilisation des fonds domestiques et des budgets alloués à la santé des pays pour renforcer les systèmes de santé, la santé communautaire et bien sûr la lutte contre le paludisme. Nous gagnerons la lutte à travers un engagement communautaire fort et la société civile a un rôle clé à jouer dans la lutte contre le paludisme. Sa contribution permettrait non seulement de renforcer l'engagement communautaire de nos pays, mais aussi d'atteindre les communautés vulnérables dans les zones les plus reculées et renforcer l'adoption et la bonne utilisation des outils de prévention et le recours aux soins. Ainsi, je remercie les organisations de la société civile qui, au quotidien, soutiennent les programmes de lutte contre le paludisme et servent de relais entre les communautés et les systèmes de santé pour sensibiliser celles-ci sur les moyens de lutte contre le paludisme. Ainsi, profitons de cette occasion pour renouveler nos efforts et notre engagement dans la lutte contre le paludisme. Au nom du partenariat RBM, je vous félicite tous ici pour le travail important que vous faites chaque jour en tant qu'OSC pour lutter contre le paludisme et je vous remercie sincèrement pour votre engagement. Restons engagés dans ce combat. Le moment est venu, nous pouvons et nous mettrons fin au paludisme. Merci et je vous souhaite à tous une réunion productive. La lutte contre le paludisme doit rester une priorité dans nos pays. Aucun enfant ne doit mourir de cette maladie qu'on peut prévenir et guérir. En travaillant ensemble, nous allons atteindre zéro palu. Je vous remercie.
Merci beaucoup. Merci, Dr. Corinne Karema, Interim CEO of the RBM Partnership to End Malaria. So we are very fortunate to have you this morning. Thank you for your key notes and message. We have understood that community engagement is key. Like you said, strong community engagement is key. If you want to deliver zero malaria in civil society, have a key role to play to speak for those who cannot speak and to make sure that the needs of the vulnerable population are taken into account. And all of this can be done thanks to the coordination of the RBM Partnership to End Malaria, which is a global mechanism to coordinate the efforts of the fight against malaria. So we are asking then everyone to Google RBM Partnership to End Malaria, join the global platform and start to contribute if you have not done so in the different working session and area so that together we can achieve the goal to eliminate malaria. So thank you. I'm very happy to introduce our next speaker, the first presentation of the day. The presentation of the day will come from WHO, the Global Malaria Program based in Geneva. And so we are also very fortunate to have with us Dr. Peter Olumese, which is a global malaria program from WHO. Dr. Peter's responsibility include development of updating of WHO guidelines for the treatment of malaria, technical support for regional and sub-regional and national malaria treatment policy development and implementation, capacity building for effective malaria disease management. Dr. Peter is the co-chair of the Country Regional Support Partner Committee of the Rollback Malaria Partnership to End Malaria. That committee facilitates and harmonizes partner support in response to countries' identified need in the establishment of the 3-1 principle for malaria. So the 3 principles are coordination, one coordinating mechanism, 1 plan, and 1 monitoring and evaluation system at the country level. So Dr. Peter really advocates for that coordination of those mechanisms. And he's one of the leaders of the malaria fight globally. He's a So we are very happy to have Dr. Peter from WHO Global Malaria Program with us, and he's going to talk to us about the malaria situation right now, the strategy and the challenges. So where are we now? Dr. Peter, over to you. Thank you.
Good morning, good afternoon, good evening. My name is Dr. Peter Olumese with the Global Malaria Program, WHO in Geneva. I want to thank the organizing committee for inviting me to give a talk on the global malaria strategies and situation and challenges. Where are we now? I'm glad to be part of the Civil Society for Malaria Elimination Annual Forum for 2023 as we mark the World Malaria Day for 2023. I have a set of slides I would speak to, just bringing us up to speed quickly as to where we are and what the current situation and challenges are. I'll just put this up if you give me a moment. Yep, sharing, I go to full slide. I have 10 minutes for this presentation. So like I said, it is the global malaria situation, strategies, challenges, where are we right now? I think I'll start from the targets we set for ourselves in the Global Technical Strategy for Malaria, and of course the accompanying action and investment to defeat malaria 2016 to 2030. And in that particular document, we set goals for ourselves as a malaria community. One, to reduce malaria mortality rates globally compared to 2015, to reduce the malaria case incidents globally compared to 2015, eliminate malaria from countries in which malaria was transmitted in 2015, and to prevent re-establishment of malaria in all countries that are malaria free. And for all of these, there were milestones and touch points in 2020, 2025, and 2030, eventual targets. And I think one thing to bring to the fore is that in developing these global technical strategies, it was agreed that all countries can and should be able to accelerate effort towards malaria elimination. Also highlighted that country ownership and leadership with participation of communities is key and important to a multi-sectoral approach. So I'm particularly glad that we have the CS4ME and that's working and mobilizing communities, not just to be part of developing this global strategy, but also as part of implementing and ensuring that we achieve the goal set. Other things include improved surveillance, monitoring and evaluation, equity and access to services, especially for the most vulnerable and hard to reach populations, and innovations in tools and implementation approaches, which indeed fits very well with the theme of World Malaria Day this year. That it's time to deliver zero malaria, innovate, invest, and implement. However, at the first milestone touch point in 2020, we were off track in two of the main big goals. One, reducing malaria mortality and reducing malaria incidents. We were off track by about 22% for mortality and about 37% for malaria cases. So we needed to find ways of coming back on track. The current estimates of malaria cases and deaths as reported in the World Malaria Report 2022 is as follows. We still have about 84 countries and territories where you have ongoing malaria transmission, which accounts for about half of the world's population being at risk. I think the big take-home message here is that it still remains that globally more than 95% of the malaria cases are in Sub-Saharan Africa. So the estimated 247 million cases in 2021, 95% in Africa, and even in terms of deaths, out of the estimated 619,000 deaths in 2021, 96% in Africa. So malaria remains the fourth highest cause of death among children in Africa, claiming the life of one child every 2 minutes. So the period we hold in this particular event, you can begin to calculate and estimate the number of children under 5 who would have died from malaria. I wanted to show this slide just to show it is not all gloomy and that there are things we can do. When COVID struck, there was the fear that that would further exacerbate malaria cases and deaths. But I think we're happy to say that the endemic countries held the line against further setbacks in 2021. You can see in death, for example, in 2019, they had 568,000. 2020, it increased to 625. But in 2021, it came down a bit, though still very high beyond what we would be happy with. And the same with cases. So invariably, despite the surge of COVID-19 and the pandemic, the endemic countries were able to hold together and put things in place to ensure that there was no escalation. And I think those are lessons to learn from, and that's why I'm showing this slide, that there was a concerted effort across the different partners, stakeholders, funders, technical partners, and all coming together to work together to mitigate the potential effect of COVID. And these 7 cross-partner work streams that provided support to countries, and I think that partly significantly contributed to the cases and the mitigating the expected rise. And I show this to say that, yes, if we work together and we continue to work together, we can indeed achieve the goals set in the GTS. However, what are some of those factors that are currently influencing and affecting the malaria figures right now, that unacceptable figures that we have? One, you have decreasing efficacy of the current control tools, resistance to anti-malaria medicines, to insecticides, and implementation challenges. Uptake and coverage of interventions is still quite a challenge. Financing, plateauing of donor funding and minimal increase in domestic financing. And against this is the backdrop of increased cost of doing business following COVID, with the resistance to medicines and insecticides, with having newer products that are more expensive than what the previous ones used to be. So even for the same amount of money, we are unable to deliver what we would have been able to deliver pre-COVID. Technical capacity, national, district, communities, we're losing technical capacities, weak surveillance systems, challenging implementing environments with conflict, humanitarian, fragile setting, the environmental and climatic disasters. So all of this contributes. I've talked about COVID-19 earlier on, and indeed emerging biological threats. And some of these include, talked about the resistance, anti-malaria drug resistance, HROP2 deletions, making some of the rather very cheap rapid diagnostic tests not as effective as they should be. However, mitigation efforts are in place. We're happy to state that the strategy to respond to anti-malaria drug resistance in Africa, and this was launched in November last year. Anopheles stevensii, another one, and this has the potential of reversing some of the gains that we've already made. And just showing this slide to show that work is actively ongoing, working across various partnerships and with the technical agencies of how to properly map and how to respond to the scourge of Anopheles stevensii. On a happy note, last year WHO recommended the use of the first malaria vaccine, the ROTSS vaccine, and since then preparations and support for rollout beyond the pilots are ongoing. Over 23 countries have expressed interest to introduce the vaccine. However, there's a mismatch of vaccine supply and demand to meet the country needs. And based on that, and to manage that effectively, there is a framework for the allocation of the limited vaccine supplies. I just killed this, yep. But the various the framework for the allocation of limited vaccine supplies, so working with countries of how best to deploy, how to target, as we gradually wait and hope for the scale up of the production of the vaccine. And indeed, hope and expectant that new vaccine candidates would be out there in the near future. Yep, the high body to high impact approach still remains the bedrock of tackling and looking at malaria control in the highly endemic countries, with the 4 pillars: the political way, strategic information, better guidance, and coordinated response. And I want to speak a little bit of political way. That is so important because country ownership and country directed interventions is so key if we need to achieve the goals that we have set for ourselves. Again, I re-emphasize the reasons why we need the community, civil societies, to, as it were, help to mobilize bottom up. We tend to do things top down, but we need involvement of the communities and of the people in defining and in designing and implementing these various interventions. The need for multi-sectoral response with trusted national leadership and well-functioning, equitable, and resilient health system. The health system needs to be functional. It needs to be a continuum from the community level to the highest possible level of healthcare. All of that is essential and required for us to achieve what we want to. Promoting innovation, we want to better anticipate for new and effective tools, innovative delivery systems for current intervention and existing tools, taking advantages of opportunities and lessons from challenges. For example, during the COVID response, how we were able to do things, thinking outside the box. How can we bring all of this to bear in malaria control? There's a promising pipeline of research and development to come with new tools, new technologies to indeed help us to get to our goal and to our targets. Yes, my time is far spent. So in conclusion, I want to say, though we are currently off track in meeting the goals and targets of the GTS, however, lessons from the past and how malaria control was before 2015 is reassuring. But given the right leadership and direction, it is possible to get back on track and achieve the GTS goals and targets. Effectively deploying and maximizing current tools, even as we wait for new ones, can already begin to get us back on track while promoting development of the new effective tools. Country ownership and leadership, I keep re-emphasizing that, remains pivotal in the fight against malaria. The multi-sectoral approach beyond just the Ministry of Health and the key players in malaria is essential and must be vigorously pursued with community involvement, both in the design and implementation of malaria control tools. So not just implementation, even in its design, and also funding from domestic and international sources must increase substantially for the GTS goals to be achieved. And so with that, just want to say thank you, everyone. Let's keep our eyes on the goal of the world free of malaria. And I want to congratulate everyone on this World Malaria Day, and let's continue to keep our eyes on the target. Indeed, it is time to deliver zero malaria, to innovate, to invest, and to implement, and we need to find our different routes in achieving this goal and this target. Thank you again for the opportunity to share with you. Bye.
Thank you very much. Thank you, Dr. Peter. Thank you for your presentation. Merci pour cette très belle présentation. So there was, we didn't have a lot of questions for Dr. Peter. So there was one question about when is the malaria vaccine will be available to everyone. Many of those responses were in the presentation, but Dr. Peter, would you like to respond to that? Okay. Yes, so thank you, Dr. Peter, if you can hear us, if you can respond to that. If not, we can send the written responses by email after the forum. So thank you very much. Thank you for this presentation. So the question about the vaccine, the response is in the forum. Some country will start piloting the vaccine already this year, and so we will be able to share with you the full response of Dr. Peter after the forum. And you will also receive the presentation in English and in French. So you will be able to go to the presentation, and if you have any more questions, we will make sure to send all the responses to you. So following the webinar, we will have a document that we call question and answer. So all of the questions that you will have for the different panelists, we will write the written answer and share with you all by email, along with the. So thank you for sharing. Like we say, we have a full day today, so we're going to go right away in our second part of the forum. And so we're going to have great speakers, including Dr. Antonio from PAMCA, Dr. Roland from the London School of Hygiene and Tropical Medicine. We will also have Dr. Patrick from Westergaard, who's going to talk about the new net. And we look forward for this second presentation. So I will hand over to my colleague, Karine, who will start the introduction of this second session.
Merci beaucoup, Olivia, de m'avoir passé la parole. Alors, dans ce panel, nous allons principalement parler de l'innovation dans la lutte contre le paludisme. Nous allons voir ensemble les dernières innovations concernant la lutte antivectorielle, concernant le TPI chez l'enfant, concernant aussi la nouvelle génération de moustiquaires et aussi voir une étude qui se fait sur la modification génétique des moustiques au Burkina Faso. Alors, sans plus tarder, je vais passer la parole au docteur Antonio, qui est chercheur senior à l'OCEAC et qui est aussi le président de l'Association panafricaine de lutte contre les moustiques. Docteur Antonio, nous aimerions que vous nous parliez des défis de la lutte antivectorielle dans la lutte contre le paludisme. Merci beaucoup. À vous la parole.
Thank you for giving this opportunity. My name is Antonio Conjo. I'm a medical entomologist working for OCEAC in Yaoundé, Cameroon. I'll be talking to you about malaria vector control in Africa, situation and challenges. So the outline of my presentation is what is presented here. First, I'll be talking about the situation of malaria in the world, challenges, other trade, and new advances in malaria prevention. So malaria continues to be an important public health problem across the world. Over 247 million cases were recorded in 2021, leading to over 600,000 deaths. In this map below here, you will see the situation of the disease across the world, and Africa is the country still most affected by the disease. Let us look more specifically on the situation of malaria across the African continent. We can maybe range countries in the continent in three categories. The top 5, which are the most affected by malaria, including Nigeria, DRC, Congo, Uganda, Mozambique, and Niger, where the situation is very alarming. You have on the other end, countries which are close to malaria elimination. These include Cape Verde, Eswatini, Botswana, Sao Tome, and South Africa. And in between the two, you have countries where the situation is more stable, with no great evolution of the situation of malaria in the recent years. According to the Global Strategy of Malaria Control, 2016-2030, we need to achieve over 90% reduction of both malaria morbidity and mortality by 2030 from the level of 2015. And the number of countries which should be free of malaria during this period should also increase during this time frame. But let us look at the trend. Are we really so if we look at morbidity and mortality, we'll see that despite the fact that there was a great decrease of this indicator between 2000 and 2015, since 2015, the situation is more stable for these two indicators. Now, let us look at what was expected and the current evolution of the disease. So if we continue to do what we are doing nowadays, the gap between what is expected, the expected trend in the reduction of malaria cases compared to the current evolution, which is continuing to increase. I just want to emphasize that for the moment we have 40%, a gap of 40% that we need to cover. And if we doesn't do that, the gap will continue increasing. What do we have as control measure for fighting against malaria? We have Treatment, which is used by over 90% of the population affected across the world. Between 2004 and 2021, over 2.2 billion IT were distributed across sub-Saharan Africa. This making the ownership rate to increase to about 68% and the US rate to be about 47%, though this level is still not very high compared to what is expected. The other control measure that is being used is indoor residual spraying, which utilization is decreasing across affected area. From 5.5% of the population covered by these control measures, it is now 2.4% of the population which is covered by these control measures across the world. Vector control measures, including bed net and indoor residual spraying, were very important were crucial for the reduction of malaria morbidity and mortality, which occurred between 2010 and 2015. They were responsible for over 70% of the reduction occurred during that time, showing the real importance of vector control in the elimination process of malaria. If we look at previous trials which have been conducted across Africa for controlling vector population, we'll see that these trials were also using vector control measures were responsible for a decrease of malaria close to elimination. And because there was no sustainability in control intervention that were being put in place in most of the settings, malaria took off again. So there is a need for us to be consistent in the implementation of vector control measures in order to achieve elimination of malaria. What are the current challenges that vector control is facing now and which is affecting its efficacy? We'll say, first of all, will be the limited number of insecticide which is being used in public health. And second will be the rapid expansion of insecticide resistance, which is now largely spread across the world. And there is also the change in vector feeding, biting, and resting behavior, and the non-use of bed net by the population, which are all affecting the effectiveness of these control measures. So how can we address these two? For example, insecticide resistance. So according to the World Health Organization, the rotation of insecticide of different families could be used in order to address this issue. Or we can combine also different tools such as indoor residual spraying or to control the top population. We have the example of the onchocerciasis control program, which was conducted in West Africa between 1974 and 2002. So during this period, when resistance to temifos appeared, what they do, they put in place a rotation of 3 unrelated insecticides, including temifos, chlorphosphine, and BTI. And using this method, they were able to control black fly for over 20 years. Now, how can we address the shortage of insecticide? The World Malaria Report tells us that 28 vector control products are in research and development pipeline. 11 of these products are new insecticide. 7 are insecticide for indoor residual spraying. 13 are in the data generation stage. 7 are undergoing epidemiological trial, and 6 are accessed by WIF for pre-qualification. Some insecticide, new insecticides are now available for vector control, such as chlorpheniramine or chlorgenidine. This clearly showing us that things are moving backward, and it will also enable more to us to be very efficient in fighting against malaria. New monitoring procedure for new insecticides are now available and can also be used in order to assess the efficacy of this tool. Other products have also been produced, such as new larvicide, which are now available. So the way forward could also be combining control intervention, where this intervention could be efficient or suitable in order to achieve malaria elimination, or interventions such as larviciding or indoor residual spraying. will be combined with live research, house improvement, or gene drive, when this will be available in order to control vector population efficiently. We have other threats which are also affecting control, such as urban malaria. We know current forecasts estimate that over 70% of the population in sub-Saharan Africa will be living in urban settings by 2050. And there is also this increase in urban malaria, which is increasing in most settings across Africa, which is due to unplanned urbanization. Unplanned urbanization leads to focal transmission, making that we need to really address this in order to control a vector population. There is also the invasion of new species, which could increase transmission pattern and affect control measures. So recently, the World Health Organization and the UN Habitat developed a global framework for malaria control in urban settings, where it is said that malaria response needs to be part of a broader urban development and health agenda plan. So this need to be taken into consideration. There is also the invasion of new species, such as Anopheles stephensi, which could hamper effort malaria elimination. We have Anopheles stephensi, this vector which is coming from Asia, which invaded the Horn of Africa, and which was responsible for the resurgence of malaria in Djibouti. This vector is now spreading in the Horn of Africa and also in West Africa. So this vector is known to be to rapidly adapt to different type of habitat and also resistant to different insecticides. Recently, in September, the World Organization launched a new initiative to stop the spread of Anopheles stephensi in Africa. This includes enhancing collaboration, increasing surveillance, and developing guidance and prioritizing research for controlling malaria across this vector expansion across Africa. There is also pandemic which can affect the elimination of malaria. We still have fresh in mind the COVID pandemic, which disrupted the delivery of essential goods for malaria prevention or malaria case management. And this pandemic was responsible for over 30 million more cases of malaria across the world. So all this needs to be taken into consideration for the fight against malaria. The good news here is that we now have two vaccines which have been produced, the RTS vaccine and the JSCA vaccine, and which can be combined to existing control measures in order to fight against malaria and drive elimination agenda. So the take-home message is that not one actor could be able to eliminate malaria. We need to put our hands together in order to fight efficiently against malaria and eliminate the disease. Integrated vector management should be key in the process of malaria elimination across Africa. So this to be taken into consideration. This is what I have for you today. Thank you again for listening.
Merci beaucoup, Dr. Antonio, d'avoir partagé avec nous votre expérience sur la lutte antivectorielle. Nous savons que c'est très important pour la lutte contre le paludisme. Alors, sans plus tarder, nous allons passer la parole au professeur Rolly Gosselin, qui est professeur en santé mondiale, qui nous vient d'un grand institut basé à Londres et qui est très connu pour ses travaux de chimioprévention dans la lutte contre le paludisme. Le professeur Rolly, il va partager avec nous ses connaissances et aussi le fruit de ses recherches au sujet de la prévention du paludisme chez le nouveau-né, notamment avec l'utilisation du TPI. Professeur Rolly, vous avez la parole. Merci.
Hi, my name is Rolly Gosling. I'm a professor at the London School of Hygiene and Tropical Medicine in the United Kingdom, and my talk is on perennial malaria chemoprevention, PMC. Why do we care about chemoprevention in children? Well, we care about chemoprevention in children because the youngest are the most vulnerable to the ravages of malaria. For example, in the graph on the right, you can see that deaths marked in black, severe anemia marked in pink, and requirement for blood transfusion is highest in the youngest children, but essentially below the age of 2 years of age. Well, what is PMC? Well, PMC is based on the platform of intermittent preventive treatment of malaria in infants, IPTI. And this was a guideline set out in the early 2010s by the WHO, which recommend the provision of sulfadoxine pyrimethamine, SP, at times of immunization of the Penta 2 and Penta 3 and measles vaccinations, approximately at 10, 14 weeks and 9 months of age. The IPTI should be given in areas of non-seasonal malaria with moderate and high endemicity of malaria, and implemented in areas where genetic markers of SP resistance, which we call the 540E, were less than 50%. IPTI was actually only ever implemented as a programmatic tool in Sierra Leone, but the evidence for the cost effectiveness of IPTI was very good. And here below you can see the evidence that was generated in the early 2000s where the IPTI regimen 3 times in the first year of life reduced malaria incidence by 30%, reduced anemia by 21%, and reduced hospital admissions by around 40%. So what does PMC do? Well, PMC extends these IPTI guidelines, and this new guidance was released in June last year. Now, PMC is recommended that chemoprevention is given beyond the age of 1 year, and in the guidelines it recommends up to 2 years, but does say you can go higher if you want. It increases the number of contacts from 3 in the IPTI maximum. You can give as many doses as a program would like. And the delivery channel is expanded beyond the immunization channel, the EPI channel, to include vitamin A, and in one of the pilot projects that I'm going to talk about, to community health workers as well. Any drug can be used, but SP remains recommended, and you can use SP in areas where there is more than 50% of the 540E mutation now. PMC is still recommended in areas of non-seasonal malaria with moderate and high endemicity. So current PMC implementation and research projects are being supported by 4 different grants at the moment. The PLUS project, the one that I work for, is currently implementing PMC in Benin, Cameroon, Côte d'Ivoire, and Mozambique. The Malaria Consortium is soon to start a project in Nigeria. Similarly, PATH will soon start a project in DRC, and the Multiply project, run out of IS Global in Barcelona, has a project which will soon be starting in Mozambique, is currently running in Sierra Leone, and soon to start in Togo. So just briefly about the PLUS project. The PLUS project is a UNITAID funded project with several partners listed below. In Benin, Cameroon, Côte d'Ivoire, and Mozambique, we have done a co-design process that I'm going to talk a little bit more about. We've started implementation, and our evaluations are beginning now, which will study the country-adapted models of PMC that are currently integrated into the existing health systems. We also have some light touch evaluations and policy adoption to support the rollout of PMC in DRC, Ghana, and Zambia. We're conducting several evaluations, which I'll come to later again, which will help our countries and other countries decide where and how to scale up PMC. And we are sharing our learnings from implementation experience and the research evidence through all variety of channels, but include a community of practice which listeners may be interested in. So our major innovation for PMC in this project was a process we call co-design. So as you've probably noted, the WHO guidelines are very flexible, and countries need to select quite a lot of issues, including the age limit of the intervention, the number of contacts and how the health system will deliver those contacts, the drug used and where to implement. So to support the design of this tailored strategy to support each country, we set up these co-design workshops, and these were workshops that included multiple stakeholders, the malaria, the immunization programs, district and provincial health system, amongst others. We mapped out possible contacts, and on the right you can see a picture of the journey mapping that we did, which was the times that children came into contact with the health system where we could potentially provide PMC. And from this, the countries derived their own models of PMC. So I'm going to go through the models that were chosen by our 4 countries. So first of all, Cameroon. So they chose an 8 contact model, and the orange circles indicate an EPI contact, so DPT2, DPT3, measles 1 and measles 2. And they also used vitamin A contacts as possible contacts at 6 months, 12 months, 18 months, and 24 months. Notably in Cameroon, once a child was older than 6 months, or is older than 6 months, community health workers can deliver PMC if the child has missed a dose. Benin chose a very similar regimen, but without the community health workers being able to actually deliver the PMC, an 8 model contact. Mozambique chose a 4 model contact, although I think that this might be under change now, but they essentially chose 3 EPI contacts and 1 vitamin A contact. I believe there's going to be another EPI contact added to that. And Côte d'Ivoire picked a 5 contact model, 4 using using EPI immunization and 1 using vitamin A. Where are we in implementation? Well, the PMC started in late 2022 in Côte d'Ivoire, Benin, Cameroon, and it started just now in Mozambique. Anecdotally, PMC is widely accepted by caregivers. Many of them received IPTP and they understand the process. Routine M&E data is now incoming on SP and doses given and stock of SP, and supervision of PMC started in Côte d'Ivoire, Benin, and Cameroon. And we believe the early feedback is certainly that PMC is being delivered in line with training. There's few reports of vomiting, although there is some confusion identified about catch-up schedules. So if a child didn't get it, when should they be able to get it? We will be running routine data quality activities starting in the next couple of months. There are 6 evaluation packages. Policy adoption and receptivity is the process of how the co-design goes and how the adoption of the new WHO guidance is. We're doing an impact evaluation focusing on Côte d'Ivoire and Cameroon. We're looking at the SP suitability. So this looks at how genetic resistance mutations impact on efficacy of SP for PMC. We're looking at a process evaluation focusing on coverage and equity, and an economic valuation looking at cost effectiveness. All these will feed into a decision tool which will be available for programs to help guide setup and scale up of PMC in other countries apart from the ones that we're focused on. We are sharing evidence through several different channels, but I'd like to highlight the PMC Community of Practice, which is the next meeting is on April the 12th between 1300 and 1500 GMT, and I wish that you would contact me for further information. My contact details and those of other leaders as the directors of the programs are on the next slide. Thank you and merci.
Thank you very much. Merci beaucoup, professeur Roland, de nous avoir édifié sur cette question importante de la prévention du paludisme chez l'enfant. Nous savons que ils font partie des populations les plus vulnérables, ainsi que les femmes enceintes. Alors, sans plus tarder, nous allons parler de la moustiquaire imprégnée à longue durée d'action, encore en abrégé la MILDA, avec Monsieur Patrick Sayens, qui nous vient de Vestergaard. Nous connaissons tous Vestergaard, c'est une entreprise reconnue sur le plan mondial et aussi reconnue par l'OMS comme fournisseur mondial de moustiquaires dans le monde entier. Et nous connaissons tous l'importance de l'utilisation de la MILDA. Monsieur Patrick Sayens va nous parler de la nouvelle génération de moustiquaires imprégnés, ce que ça peut apporter en plus et pourquoi est-ce que Vestergaard la préconise. Merci beaucoup. Thank you very much. Mr. Patrick, you have the floor. Thank you.
Hello, my name is Patrick Sayens. I'm the head of global growth and advocacy at Vestergaard, based in Lausanne, Switzerland. I'll be speaking about the importance of both innovation in products and in partnerships, highlighting an exciting new WHO pre-qualification in the new NETs category. I think we all understand that the fight against malaria is far from over. We're not seeing the reduction in cases and deaths that we had hoped for. Insecticide resistance is widespread and increasing, and it is actually one of the most concerning biological threats and one that could derail malaria control and elimination efforts. Long-lasting nets, LLINs in general, will continue to be the most effective and widely used prevention tool against malaria for many years to come. They're responsible for averting up to 70% of all malaria cases. And LLINs, particularly PBO LLINs, like our Permanent 3.0, have become the standard of care. They're still efficacious and they provide an excellent, cost-effective solution in reducing malaria mortality rates. However, the rapid spread and intensity of insecticide resistance to the insecticide classes recommended in vector control tools requires us to identify and develop new insecticides and LLINs for public health. And you may have seen the World Health Organization's new recommendations on 2 new classes of insecticide-treated nets, as well as updated guidelines. These guidelines consider that nets containing 2 active ingredients are needed to control malaria and to provide the highest levels of protection against pyrethroid-resistant mosquitoes. As such, the WHO issued a recommendation for PBO nets and a strong recommendation for the deployment of the new generation pyrethroid chlorphenapir nets that have been demonstrated to reduce malaria cases by nearly 50%. Vestergaard is delighted that Permanent Dual, our first pyrethroid chlorphenapir dual active ingredient net, has indeed been pre-qualified by the World Health Organization in the new nets category. A Permanent Dual combines 2 insecticides, deltamethrin and chlorphenapir, enhancing the ability of Permanent Dual to kill increasingly pyrethroid-resistant malaria mosquitoes. Permanent Dual is a soft polyester net, and like Permanent 2.0 and Permanent 3.0, it offers the highest level of user comfort, made from the softest, most breathable polyester material, thereby increasing the likelihood of better utilization. Now, this is excellent news for the bed net industry, as malaria endemic countries, specifically those battling with intense insecticide resistance, can now deploy a new generation of bed nets that can kill up to 70% more mosquitoes than pyrethroid PBO nets. This makes Vestergaard the first company with a fully comprehensive portfolio of long-lasting insecticidal nets for the prevention of malaria. The conclusion of the WHO pre-qualification is based on an assessment of the safety, the efficacy and quality, and provides guidance to United Nations agencies, WHO member states, and national malaria control programs on their procurement decisions. Given that our global efforts to eliminate malaria have not yet yielded the results we had hoped for, we have to identify ways to rapidly scale up deployment of new generation nets like Permanent Dual. And the overall permanent manufacturing platform does enable us to produce Permanent Dual rapidly at scale, and thereby supporting the expansion of the dual active ingredient net segment. You might be asking, why is a strong recommendation from WHO on the new dual active ingredient nets so important? Well, we simply have to protect the very fragile gains conferred by the bednet. The latest World Malaria Report actually tells us that. So our efforts are flatlining, and in several instances we're slipping backwards. And although it might seem that we just need to get more bednets out there, there's a growing body of countries that are shifting away from a traditional universal coverage approach over to a more effective coverage approach by embracing these new, more efficacious tools. And so we are keenly aware that this is a critical decision-making moment with success in the balance. We're approaching the last mile in the fight against malaria, and we expect it to be the hardest one. Rooting out pockets of malaria in the toughest to reach, most remote and underserved areas of the world where insecticide resistance is threatening progress. We must dramatically step up our efforts to ensure that the highest quality, most efficacious tools are distributed efficiently, transparently and equitably to areas where they are needed the most. For us, it means embracing these next generation dual active ingredient nets as the new standard of care, while we continue to innovate new tools. The world is counting on us to do so. But we must recognize that innovation does not stay innovative for long. We have to continue innovating faster than the mosquito mutates. And we have to work tirelessly to break down existing barriers and accelerate impact at scale. But I'd also like to take this opportunity to speak to the importance of partnerships in the fight to eliminate malaria. Collectively, we can only be a force for good with great partnerships. The power of partnerships is one of the most exciting opportunities we have. Unlocking diverse capabilities, expertise in a partnership actually amplifies our impact. Arguably, we cannot deliver on Africa's economic progress and productivity without including its people and communities. And so who better to amplify the people's voice than the very communities we work so hard to protect? We're grateful for the growing partnership with civil society for malaria elimination, CS4ME, across the African subcontinent. You are a very dedicated organization, dedicated to empowering communities and civil society, really amplifying the voice of the many at risk of malaria. The African continent stands to gain so much if we eliminate malaria, and actually more so if we unlock more impactful partnerships. The malaria investment case is very clear. Meeting the 2030 malaria elimination targets would actually generate an estimated $2 trillion boost to the global economy and save approximately 10 million lives. And it's well known that every dollar invested in ending malaria is estimated to yield $40 in economic returns. And so in conclusion, we need to innovate at the product level, but certainly also at the partnership level. What's needed now is a collective approach to accelerate eradication of the disease. And so when we bring the best of our individual capabilities, competencies, skills, innovation, and join them together, we can be a formidable force in the fight against this disease. We look forward to continuously supporting CS4ME in its mission to harness the power of a global movement of civil society organizations and communities to achieve malaria elimination. Thank you.
Thank you very much, Mr. Pratik. Merci beaucoup pour votre intervention sur la nouvelle génération de moustiquaires. En effet, c'est vraiment important d'utiliser les moustiquaires à longue durée d'action, mais c'est surtout important d'utiliser les bonnes moustiquaires. Donc, merci encore pour votre intervention et pour le travail que vous faites qui nous permet de sauver des millions de vies. Alors, sans plus tarder, nous allons passer la parole au docteur Léa Paré, qui est professeur à l'Institut de recherche des sciences basées au Burkina Faso, et qui travaille sur la modification génétique. C'est toujours la lutte antivectorielle, mais précisément une technique de modification génétique. C'est-à-dire qu'elle mène depuis déjà 2 ou 3 ans un projet qui consiste à attaquer le problème du paludisme à la source en anéantissant le moustique en lui-même. L'année dernière, nous avons eu le privilège de la voir à notre forum et cette année, elle va nous parler de la deuxième phase de ce projet, de comment est-ce que ça s'est déroulé, des principaux acquis et des résultats et aussi des prochaines étapes. Docteur Léa, vous avez la parole. Merci beaucoup.
Bonjour, mesdames, messieurs. Moi, c'est Dr Léa Paretoué. Je suis chercheur à l'Institut de recherche en sciences de la santé au Burkina Faso. Et tout d'abord, je voudrais remercier les organisateurs de la rencontre aussi, CS4ME, de nous donner l'opportunité de pouvoir partager avec vous notre recherche sur les moustiques génétiquement modifiés. Nous avons déjà eu la chance de présenter cette recherche à une de vos réunions. Donc aujourd'hui, nous allons présenter l'étape suivante. Le titre de notre présentation est le suivant, Target Malaria, la recherche sur le gene drive pour l'élimination du paludisme. Target Malaria est un consortium de recherche avec plusieurs équipes de recherche basées aux États-Unis, en Europe et en Afrique. En Afrique, les pays qui participent à cette recherche sont le Burkina Faso, où le principal investigateur est le Dr Abdoulaye Diabaté. Nous avons l'Ouganda et nous avons le Ghana. La vision de Target Malaria est un monde sans paludisme. Et les objectifs de notre recherche sont principalement développer une nouvelle technologie génétique de lutte antivectorielle contre le paludisme par le contrôle des vecteurs. De manière spécifique, nous voudrons réduire la population des principaux vecteurs du paludisme à travers la modification génétique, réduire ainsi la transmission du paludisme à travers une approche à long terme, économique et durable. Lorsqu'on parle de gene drive, qu'est-ce que c'est que le gene drive? Ou encore en français, l'impulsion génétique. Les gènes avec une impulsion génétique augmentent la propagation des gènes d'intérêt sélectionnés. À partir de quelques individus seulement, un gène d'intérêt avec une impulsion génétique peut propager une modification efficacement à travers une population cible. Par exemple, si nous avons un gène avec impulsion génétique où le gène d'intérêt a pour objectif, par exemple, de rendre le moustique stérile ou encore de rendre les femelles stériles, si vous faites la modification et vous y associez l'impulsion génétique, ce caractère-là va être transféré à la population de moustiques sauvages de façon très très rapide. Et cela va se faire à travers des lâchers sur le terrain où vous allez lâcher donc vos moustiques génétiquement modifiés qui vont être en contact avec des moustiques sauvages sur le terrain. Mais avant d'arriver à cette technologie donc de gene drive ou encore moustique avec impulsion génétique, la recherche de Target Malaria se fait par étapes et nous avons 2 étapes qui précèdent cette étape de gene drive. Nous avons la première étape que nous avons appelée le moustique génétiquement modifié mâle stérile et la deuxième étape que nous appelons le moustique génétiquement modifié mâle biaisé. Nous avons terminé la première étape, donc, qui était ce moustique génétiquement mal stérile, avec le lâcher expérimental de ces moustiques au Burkina Faso en 2019. Et vous avez ici quelques images donc, de ce lâcher, parce qu'avant d'amener ces moustiques sur le terrain, nous avons fait un travail de laboratoire et avec les communautés pendant 7 ans, où nous avons caractérisé les espèces de moustiques qui existent sur le site, donc pour mieux les connaître. Nous avons donc travaillé au laboratoire à nous former au standard international donc pour pouvoir être en mesure de pouvoir travailler avec des moustiques génétiquement modifiés. Et nous avons engagé les autorités au niveau national, au niveau régional et au niveau des villages dans lesquels nous travaillons. Donc ici, vous avez le lâcher qui s'est fait vraiment en toute transparence, où nous étions accompagnés avec les autorités donc, administratives de la région de Bobo-Dioulasso où nous travaillons, et le village, les autorités coutumières et religieuses et la population du village, et la population qui a participé vraiment à se lâcher en monitorant nos activités. Maintenant, quels étaient les objectifs et les résultats de ce lâcher? Il faut tout de suite dire que ce lâcher n'avait pas pour but, excusez-moi, d'impacter le paludisme, la transmission du paludisme. Mais les objectifs étaient principalement donc de documenter de point de vue scientifique le comportement de ce moustique génétiquement modifié afin de pouvoir renseigner les étapes suivantes de la recherche vers le gene drive. Donc, les objectifs étaient principalement de mieux comprendre le comportement de ces moustiques génétiquement modifiés sur le terrain. Et nous avons eu donc à la fin de ce lâcher, les résultats escomptés ont été atteints. Et les principaux résultats, parce qu'entre autres, nous voudrions savoir si les moustiques génétiquement modifiés se retrouveraient dans les essaims. Les essaims sont des espaces de reproduction des moustiques où les moustiques donc mâles se regroupent et les femelles vont donc chercher les mâles pour l'accouplement. Nous avions voulu savoir si le moustique génétiquement modifié, du fait de la modification et du fait qu'il a été gardé au laboratoire pendant plusieurs générations, est-ce qu'il allait reconnaître ces lieux de reproduction, les essaims? Les résultats nous ont montré que ces moustiques, effectivement, reconnaissaient ces lieux de reproduction et nous avons pu capturer donc des moustiques dans ces essaims. Un autre objectif de ce lâcher était de regarder la survie des moustiques sur le terrain. La littérature nous renseigne sur la durée de vie du moustique sauvage et il était pour nous question de savoir quelle était la durée de vie du moustique génétiquement modifié. Et nous avons vu également que ce moustique génétiquement modifié vit en deçà d'1 mois, qui est la moyenne de survie des moustiques sauvages sur le terrain. Il était également question de regarder la dispersion des moustiques sur le terrain, puisque la littérature nous renseigne aussi sur cette question de dispersion par rapport aux moustiques sauvages. Et les résultats nous ont montré qu'il n'y a pas une grande différence en termes de dispersion du moustique génétiquement modifié comparé aux moustiques sauvages. Donc, en conclusion, le moustique génétiquement modifié ne se comporte pas très différemment du moustique sauvage. La deuxième étape donc, de cette recherche que nous avons commencé maintenant porte sur ce moustique génétiquement modifié mal biaisé, autolimitatif. Alors, quelle est la spécificité de ce moustique génétiquement modifié mal biaisé? Il est sans impulsion génétique, mais il est fertile. À l'opposé de la première technologie que nous avons expérimentée où le moustique était stérile, celui-ci est fertile, donc il va avoir de la dominance, de la descendance. Mais la descendance sera majoritairement mâle. Parce qu'il faut dire que le moustique sauvage lorsque ils s'accouplent et qu'ils pondent des œufs, il y a, si vous avez par exemple 100 œufs, vous avez 50 qui sont femelles et 50 qui sont mâles. Mais la modification que nous allons introduire va donner va faire en sorte que la descendance soit majoritairement mâle. Et actuellement, par rapport à cette deuxième phase, nous sommes actuellement au laboratoire pour des recherches en milieu confiné, après avoir bien entendu obtenu toutes les autorisations réglementaires, parce que vous savez, nous travaillons sur du génétiquement modifié et nous avons besoin des autorisations réglementaires du pays avant de pouvoir travailler avec ces moustiques au laboratoire. Et également l'acceptation communautaire des populations qui sont très proches de nos insectariums également. Le but, les objectifs de ces travaux de laboratoire nous voudrions confirmer que la modification donc fonctionne en observant les moustiques au laboratoire. Nous voulons étudier le comportement donc de ces moustiques génétiquement modifiés en comparaison des moustiques sauvages. Nous voulons également observer la question de la reproduction de ces moustiques donc génétiquement modifiés et surtout le transfert du gène à la descendance suivante, puisque c'est aussi un des objectifs donc de cette modification que nous sommes en train de faire pour la deuxième étape. En marge de ces études de laboratoire, qui, si elles sont concluantes, vont être donc utilisées pour déposer un dossier à l'Agence nationale de biosécurité pour avoir l'autorisation de faire des lâchers à but expérimental. En marge donc de ces études de laboratoire, nous avons entrepris une évaluation des impacts potentiels donc de ce lâcher-là dans l'environnement. Nous n'avons pas encore procédé au lâcher, mais nous avons commencé déjà à faire cette étude-là, qui est appelée en anglais ISHA, en français EIS, qui est une évaluation systématique des impacts potentiels sur les aspects environnementaux, socio-économiques et sanitaires liés à la dissémination contrôlée de ce moustique génétiquement modifié mal biaisé. Cette étude d'impact est en conformité avec les lois réglementaires au Burkina Faso. L'étude d'impact va être réalisée par des consultants indépendants en collaboration avec le ministère de l'Environnement du Burkina Faso pendant cette phase de milieu confiné, et les résultats donc seront disponibles avant que les lâchers ne soient faits en milieu ouvert. Quels sont les objectifs de cette étude d'impact environnemental? Nous voudrions nous assurer que tous les impacts du projet sur les communautés, les individus, la biodiversité directement affectés ne détériorent pas la santé des personnes ou ne détériorent pas l'environnement. Nous voulons créer un environnement propice pour optimiser les impacts positifs du projet et nous voulons évaluer systématiquement chaque impact et informer le type d'impact, l'étendue, et mettre en place des mesures de mitigation. Et nous voulons bien entendu maximiser les impacts positifs de cette recherche pour les communautés, pour l'environnement. Nous vous remercions, messieurs, madame, et merci.
Merci beaucoup, Dr Léa. Merci beaucoup d'avoir partagé avec nous ce projet innovant. Je vous l'ai dit dès le départ, nous avons parcouru ensemble avec nos panélistes les innovations que nous avons au sujet de la lutte contre le paludisme. Alors, nous remercions vraiment tous ces panélistes qui ont donné de leur temps pour participer à cette conférence. Nous sommes très reconnaissants, Dr Antonio, Professeur Roland, Mr. Patrick et aussi Dr Léa. Merci beaucoup de la part du secrétariat CS4ME et de toute la société civile d'avoir donné de votre temps pour participer à cette conférence. Sans plus tarder, nous allons écouter un message de la société civile.
Merci beaucoup, merci. Merci aux panélistes pour cette très belle présentation. Merci, Dr Léa, de nous avoir édifié sur les modifications des gènes des moustiques et l'impact que ça peut avoir comme innovation dans la lutte contre le paludisme. Dr Léa qui nous vient de l'Institut de recherche en sciences et de la santé du Burkina Faso. Merci, Dr Léa. Patrick de Westergaard, il y a eu beaucoup de commentaires sur les moustiquaires imprégnés. On a noté tous vos commentaires, ce sont des bons commentaires, on va les partager avec les différents speakers. Beaucoup d'organisations de la société civile demandaient la fabrication des moustiquaires locales. Donc, ce sont des initiatives qui sont en cours par plusieurs partenaires. Donc, on espère que la nouvelle moustiquaire qui est plus efficace et plus résistante aux différents problèmes de résistance sera une moustiquaire qui pourra être fabriquée localement. Mais en attendant, le rôle clé de la société civile dans l'utilisation de ces moustiquaires-là est très important, comme vous l'avez tous dit. Et nous allons continuer avec la troisième partie de notre forum. On aura un message de la société civile. Ensuite, on aura l'honneur d'avoir Peter Sands lui-même, qui est le directeur exécutif du Fonds mondial, qui sera avec nous. On aura aussi Dr. Phone Shine, qui vient de Apalma de Singapour, du côté de l'Asie, de l'Alliance des leaders asiatiques pour l'élimination du paludisme. Et on aura un panel des organisations de la société civile venant du Ghana avec Mme Cecilia, du Sénégal avec Babacar Cham, de la Zambie avec Amou Mudenda et Emily de Uganda, et aussi Zenabou Ide de Impact Santé Afrique. Donc, nous vous prions de nous rejoindre dès maintenant pour cette session. Ensuite, après cette session, on aura une pause de 10 minutes pour vous permettre de revérifier les connexions Internet, d'aller boire un peu d'eau, prendre un peu de café, et puis on pourra continuer avec la dernière partie du forum. Donc, nous allons continuer avec la troisième partie qui va commencer juste après les vidéos des organisations de la société civile. On va enchaîner avec le message de Peter Sands, qui est le directeur du Fonds mondial. Merci à tous.
Aujourd'hui, je voudrais vous parler de cette maladie qu'est le paludisme, l'une des plus vieilles maladies au monde, une maladie qui se guérit et qui peut s'éviter. Mais malheureusement, elle continue de faire des ravages dans les rangs de nos pays, notamment chez les moins de 5 ans.
Je vais citer un peu une des causes de cette augmentation de cas de paludisme qui font des ravages donc, au niveau de certains districts de quelques régions du pays, qui a été évoqué par les populations bénéficiaires eux-mêmes. C'est le prix à payer pour se faire soigner quand on est atteint de paludisme. En effet, la gratuité est là de voir un peu comment accélérer la couverture santé universelle. Comment accélérer la couverture santé universelle pour vraiment adresser ce problème évoqué par les populations.
Les populations vivant dans les coins les plus reculés sont vraiment les plus vulnérables, en l'occurrence les femmes enceintes et les enfants de moins de 5 ans. Alors, augmenter les activités d'une couverture sanitaire universelle pourra vraiment permettre de réduire cette incidence.
Il est extrêmement important aujourd'hui, si on veut arriver à l'élimination des 3 maladies d'ici 2030, que nos ressources au niveau du pays soient mobilisées et mises à contribution dans le financement de la santé. On ne peut pas laisser la santé des populations dans les mains des partenaires techniques et financiers comme le Fonds mondial. Il nous appartient aujourd'hui de développer les stratégies qui nous permettent que ce soit le secteur privé, que ce soit le secteur public, mais aussi des bonnes volontés de pouvoir mobiliser les ressources au niveau du pays afin de financer la santé.
Souvenez-vous, la promesse faite à Abuja d'allouer 15% du budget de l'État à la santé. Il est temps. Il est temps de regarder cette promesse maintenant.
Chers leaders africains, la société civile vous demande de bien vouloir honorer vos engagements en se rassurant que dans tous les budgets au niveau national, on a bien réservé 15% pour allouer à la santé et qui vont servir, ces investissements serviront à aider à sauver des vies, des milliers d'enfants qui meurent du paludisme dans nos pays.
I'd like to appreciate world leaders for all the investments they have made in the reduction of malaria. However, I implore you to be intentional in channeling investments for community-led malaria programming and surveillance.
Women for Global Fund calls on the Global Fund and national political leaders to address gender inequalities in malaria-endemic countries by investing in gender transformative actions and by incentivizing the implementation of the Malaria Matchbox Toolkit to guide important approaches that address inequalities in malaria strategies at the national level.
Bonjour à tous les participants connectés pour ce forum à l'occasion de la Journée mondiale de lutte contre le paludisme. Bonjour à tous et c'est vraiment un plaisir pour moi de modérer cette deuxième partie du forum aux côtés de speakers très brillants. Et nous allons justement commencer par l'un des guest speakers de ce forum. Il va aborder la thématique de la mise en œuvre et du financement des programmes de santé. C'est un monsieur qui a eu une éminente carrière dans le domaine bancaire avant de devenir en 2018 directeur exécutif du Fonds mondial de lutte contre le paludisme, la tuberculose et le VIH-Sida. Il nous fait le très grand honneur d'être parmi nous aujourd'hui et je pense qu'on ne le présente plus, Monsieur Peter Sands.
Distinguished members and guests of CS4ME, ladies and gentlemen, 5 years ago, in Melbourne, just before the first Malaria World Congress, I was proud to witness the birth of a remarkable movement. The malaria civil societies of the world came together and spearheaded the creation of Civil Society for Malaria Elimination, or CS4ME, with the mission of supporting strategy and advocacy to eliminate malaria. This fight against malaria is at a historical turning point. Climate change is fueling an increase in malaria cases. The geographic scope of the disease is changing as highlands become warmer and wetter. Floods from climate change-driven extreme weather events are resulting in upsurges in malaria, among other diseases, in the tropical and equatorial zones of the world. Meanwhile, the parasite is becoming more resistant to treatment, and the mosquito more resistant to insecticides. And we're also seeing the spread of the Anopheles stevensii mosquito to Africa. That's the negatives, but on the positive side, we're seeing some fantastic innovations to help us counter these threats and accelerate the path to elimination. The dual insecticide mosquito nets pilots that we funded in Tanzania and Benin have been so successful that WHO have recently endorsed them as best practice. We are increasing our investment in seasonal malaria chemoprevention, a highly cost-effective tool to protect young children through the rainy season when they are most at risk. And we're also seeing the first rollout of a malaria vaccine, one of several such vaccines that have been or are being developed using new and emerging technologies. And no less transformative than the biomedical tools are the innovations in programs aimed at working with communities, supporting malaria education, and disseminating knowledge through civil society organizations. These turning points, both positive and negative, have one thing in common. They require more money. To counter the threats, we need more money. To make full use of the new tools, we need more money. And funding for malaria plateaued over a decade ago, and by 2021 was under half the global target. And a handful of international donors are responsible for 2/3 of malaria funding, and domestic financing remains woefully inadequate. The Global Fund alone is responsible for 63% of external financing for malaria programs. As a result of these dynamics, the epidemiological trends, the inadequate funding, malaria cases are sadly rising, and deaths remain far too high, with a child dying of malaria every minute. While our ability to reverse climate change may be limited, we can mitigate its impact. We can act to raise more funds to pilot and scale up malaria innovations, support community systems, including the vital work of community health workers, and enable civil society to take a leadership role in the fight against this terrible disease. I want to thank all of you for supporting the Global Fund to reach the 7th replenishment outcome of $15.7 billion, an unprecedented sum. Our country allocations will allow partners to expand programs that work, to find innovative solutions to new challenges, and to fulfill the strategic aim of defeating malaria while maximizing the engagement and leadership of affected communities, and to mainstream gender equity and human rights. Your support remains critical. I thank you for advocating for increased pledges and more domestic financing for health. I'll call out Babacar Thiam in Senegal or Rachel Nander Kalanda in DRC, whose advocacy obtained commitments from their governments for increased domestic spending and Global Fund pledges. They're great examples. We'll also continue to count on you to hold governments and global health organizations accountable for our investments and program implementation. And your role in disseminating knowledge and good practice within communities and supporting community health workers to improve their working conditions also remains fundamental. Together, we can surmount the challenges, we can beat malaria, and we can end the disease as a public health threat. Thank you.
Merci infiniment, Monsieur Peter Sands, pour ce message très profond, ce message très inspirant. Merci pour ces incitations et ces encouragements. Sans plus tarder, nous allons traverser du côté de l'Asie avec le docteur Fonsi. Bonjour, docteur Fon. Le docteur Fonsi est le directeur associé du réseau Asie-Pacifique pour l'élimination du paludisme. Il a plus de 16 ans d'expérience dans des organisations comme l'UNICEF, comme Save the Children. Et le docteur Fon va nous parler des enjeux et des défis de la lutte contre le paludisme en Asie. Docteur Fon, vous avez la parole.
I would like to thank Civil Society for Malaria Elimination for inviting APLMA to present in the CS4ME Annual Forum 2023. I am Pong Sing, Associate Director from APLMA based in Singapore. I will present how Asia-Pacific countries are trying to achieve the regional malaria elimination goal by 2030. First, I will introduce APLMA admin and explore the overall malaria situation in Asia-Pacific. Then I will go deep dive to malaria endemic countries, namely Papua New Guinea and the Solomon Islands. After that, I will share some experience from near elimination countries and malaria-free countries. Finally, I will present how we are collaborating with civil society networks and platforms. APLMA stands for Asia Pacific Leader Malaria Alliance. unite the governments in Asia Pacific who have committed to eliminating malaria in the region by 2030. APLMA translates evidence to advocate for policy change at the highest level of government. The Asia Pacific Malaria Elimination Network, ADMAN, is a network of national malaria programs from 22 Asia Pacific countries and 53 partner institutions. ADMAN facilitates regional and multi-sectoral collaboration around evidence-based practice and research to reach the elimination goal. Also, ADMAN facilitates technical exchange through its 3 working groups on surveillance and response, further control, and virus. According to the WHO World Malaria Report 2022, out of the estimated 241 malaria cases, Asia Pacific contributed to only 1.79 million cases in 2021. Among them, Papua New Guinea contributed 36% of the total malaria burden, followed by Pakistan, Indonesia, and India. Those 4 countries contributed about 85% of the total malaria cases in Asia Pacific countries in 2021. On the other hand, it is indeed commendable that some countries in Asia Pacific have made significant efforts in reducing malaria cases. When we did deep dive to the most endemic country in the Asia Pacific, PNG is an island country with diverse population and a variety of languages. 35% of the total population is residing in malaria endemic areas. Despite the challenges they face, the country has set an ambitious goal of achieving malaria elimination by 2030. From 2014 to 2017, the number of malaria cases had increased 9-fold. And the key factors that contribute to the high burden of the malaria include the limited financial resources and unavailability of malaria commodity. In addition, it is recognized that climate change can have a significant impact on the transmission of malaria, particularly in areas where the disease is already endemic. The Solomon Islands contributed only 5% of the total malaria cases, but the annual parasite incidence is the highest in the Asia Pacific countries in 2021. The reason behind very high API were insufficient further control and anti-malaria commodities, plus underreporting. The WHO launched the E2020 initiative of malaria eliminating countries in 2017 and revised to E2025 countries in 2021. Under this initiative, countries have developed national malaria elimination plans, implemented targeted interventions, and strengthened their surveillance and response systems. However, some countries in the Asia-Pacific region will require extra efforts to meet the E2025 targets. Those countries need targeted interventions and additional investment to improve access to effective prevention, treatment, and surveillance measures, plus cross-border collaboration with neighboring countries. So how about the lesson from malaria-free countries? As we all know, Sri Lanka attained the malaria elimination certification from WHO in 2016, while Algeria in 2019, China in 2021, and Azerbaijan in this year 2023. The success of this country was attributed to several factors, including strong political leadership and ownership, sufficient resources, effective surveillance system, and targeted interventions such as further control and case management. The achievement of this country highlights the importance of sustained commitment and investment in malaria control and elimination efforts. As we all know, the community participation is essential for the disease eradication and elimination, and should be centered in all malaria programs. Civil society organizations have been implementing the malaria intervention to reach hard-to-reach and remote community members, and CSO play an important role to complement and support the respective national malaria programs for malaria elimination. We have been collaborating with CSO and civil society organizations and networks and platforms to reach our malaria elimination goal. As I mentioned before, UNMAN is the network with 53 partner institutions, which include CSO and NGO. I would like to highlight some of the activities collaborated with civil society networks. The mapping of CSO in South Asia has done with CS4ME and ISA, which is a valuable initiative that can help identify opportunities for collaboration and coordination between different organizations working towards health for all. Besides, the case study has developed together with Malaria-Free Mekong on how GMS countries are moving towards malaria elimination during the COVID-19 pandemic. It is also an important contribution to the global. And CSO platform participated in the interactive session on 137 strategy and community resilience at the Malaria Week APLAMA senior official meeting in Bangkok. The session also presented how CSO played a role in promoting best practices and reaching malaria services to at-risk population. Last but not the least, the participation of CSO in the admin webinars is a valuable opportunity for knowledge exchange and collaboration among the different organizations, governments, and stakeholders involved in malaria control and elimination efforts. So, we hope to see everyone at the next annual forum. Thank you and have a pleasant day.
Thank you so much, Dr. Fon. Your very interesting presentation allows us into the first panel of this forum, the first discussion panel. We are going to talk about engagement of key targets like mayors, like parliamentarians, like the private sector by civil society. For this discussion, I am with Zainabu Ide, Amu Mudenda, Cecilia Seno, Emily Katahikawe, and Babakar Thiam. Without further ado, let's introduce Zainabu Ide from Cameroon and ask the first question: how can civil society organizations engage with the private sector to mobilize more resources for the prevention and for the treatment of malaria? Zainabu, you have the floor. Thank you.
Ok, merci beaucoup, madame. Je me présente d'abord, je m'appelle Zainabou Idé et je suis responsable de plaidoyer à Impact Santé Afrique. Donc, merci beaucoup pour cette question. D'abord, il faut savoir que la société civile joue un rôle entre la communauté et même les parties prenantes dans le secteur privé qui en fait partie. Donc, je peux donner quelques pistes quand même de réflexion. Pour la première, c'est de savoir que le secteur privé peut contribuer effectivement dans la prise en charge et l'accompagnement, notamment des agents de santé communautaire, qui se révèlent vraiment être des maillons très importants dans la prise en charge, la prévention et le traitement des communautés par rapport au paludisme, parce que ce sont vraiment ces personnes qui sont sur le terrain et qui aussi sont issues de la communauté. Donc, grâce aux agents de santé communautaire et données du Programme national de lutte contre le paludisme en 2021, les agents de santé communautaire ont pu soigner plus de 2 millions de personnes dans les communautés, ce qui n'est vraiment pas un acte qui est négligeable dans le système de santé. Ensuite, comme deuxième piste de réflexion ici, il y a la contribution du secteur privé dans la recherche et l'innovation. Je m'explique. Par rapport à par exemple, financer les recherches dans les vaccins peuvent être tout simplement donnés aux nourrissons ou aux enfants de moins de 5 ans pour justement aller dans ce système de prévention de paludisme. Il y a aussi les campagnes de CPS, donc c'est chimio-prévention saisonnier qui permettent en fait de donner des médicaments à des enfants qui sont situés dans la zone plutôt sahélienne. On a remarqué que lors de certaines périodes, il y a plus un pic de paludisme où les enfants sont plus ou moins prédisposés à avoir beaucoup plus facilement le paludisme. Donc, le secteur privé peut vraiment balancer la balance comment on va dire ça, la balance de prévalence du paludisme. Et aussi, il y a à savoir la responsabilité sociétale des entreprises qu'on appelle RSE. Donc, il y a au sein des grandes entreprises, en tout cas, et même pas que, il y a ce volet social que les entreprises peuvent avoir. Donc, de ce fait, on peut parler aussi du mécénat. On sait que les entreprises, pour leur visibilité, peuvent avoir une certaine allocation qu'ils peuvent mettre, par exemple, lors de matchs, je dis n'importe quoi, mais lors de matchs de football ou bien dans les stades, ils peuvent avoir cette visibilité et payer pour cela. Pourquoi ne pas les encourager aussi à faire des actions concrètes et fortes dans les campagnes, par exemple, et avoir leur branding quelque part. Je pense que vraiment, c'est en tant que société civile, on peut inciter le secteur privé à investir encore plus dans la lutte contre le paludisme, même les SMS que, par exemple, les entreprises de télécommunications peuvent faire pour les messages de prévention, peuvent tout au moins servir. Et il y a beaucoup d'autres choses que vraiment le secteur privé peut faire. Donc, de façon globale, que je peux dire par rapport au secteur privé dans la mobilisation des ressources domestiques, mais aussi la formation, la recherche et même le financement de certaines activités pourront leur permettre d'engager beaucoup plus le capital sympathie qu'ils auront auprès des communautés. Merci beaucoup.
Merci beaucoup, Tina, pour ce partage au sujet du secteur privé. Mais nous savons que ce n'est pas la seule cible. Les parlementaires également jouent un rôle clé et très, très important dans les questions de financement de la santé et de budget de la santé, surtout à l'Assemblée nationale. Donc, nous allons demander à Monsieur Babacar Thiam, bonjour Babacar, de se présenter et de nous dire comment est-ce que la société civile peut travailler avec les parlementaires pour que les questions de lutte contre le paludisme restent dans leurs agendas.
Merci Ségolène. Je suis très heureux d'avoir pris part à ce panel. La société civile est un des acteurs clés dans l'écosystème dans la lutte contre les 3 maladies, notamment le paludisme, le VIH/SIDA et la tuberculose, qui sont des maladies qui frappent lourdement l'économie des pays africains. Et étant donné que les parlementaires et les maires, donc les collectivités territoriales, sont des décideurs qui sont élus sur la base élective, choisis par les populations, donc ils sont investis d'une mission capitale. Et parmi ces missions capitales, il y a la mission d'assurer la sécurité sanitaire donc, des populations. Ne serait-ce qu'à ce niveau, il est très important de faire le plaidoyer auprès donc, de ces parlementaires pour mobiliser plus de ressources dans le cadre du financement de la santé. Les parlementaires, ce sont eux qui votent les lois, qui donnent le budget, les orientations claires aux États et au gouvernement afin vraiment de parvenir à résoudre les problèmes auxquels les populations font face. Donc, plaider auprès donc, de ces autorités, c'est vraiment un acte fort, un acte de stratégie qui permet d'augmenter les ressources du financement de la santé à travers la mise en contribution des ressources domestiques. C'est fondamental parce qu'on ne peut pas continuer à laisser notre santé dans les mains des donateurs extérieurs. Il faut que l'Afrique aujourd'hui se mobilise autour d'un idéal qui consiste à investir pleinement dans la santé à travers le financement de cette dernière avec les ressources dont on dispose au niveau du pays.
Thank you so much, Mr. Babacar, for this intervention. Besides parliamentarians, we know that there are religious leaders all across the world. They are very trusted. They are loved and they are heard by all the members of their communities, just as much as doctors or traditional authorities. So, about that, we are going to ask Mr. Mudenda what civil society can do to engage religious leaders in the efforts to raise more awareness about malaria. Mr. Mudenda, you have the floor.
Thank you so much. And I just want to thank our civil society for
malaria elimination who have joined us and our other partners. This year's World Malaria Day, with a theme, Time to Deliver Zero Malaria, Invest, Innovate, and Implement, calls for innovation indeed, and for more investment in the fight against malaria. For a successful community intervention, the program should understand its key partners. And for Zambia, there are three main gatekeepers, which are the traditional leaders, the civic leaders, and the faith leaders. These are among the key stakeholders. And Zambia has these three main gatekeepers who decide in terms of how the programs will run in any community intervention. And faith leaders in Zambia have a wide coverage, which covers almost every Zambian in terms of 95% are Christians, and the others denominations include the Baha'i, the Muslim, the Hindus, and the Jewish community. What can the civil society organization how can the civil society organization work with religious leaders? Yes, indeed, the faith leaders are key, and they are the voice both for the communities and also for the decision makers in terms of speaking truth to power, because the faith leaders are respected by the civic leaders and are respected by various decision makers, both from the parliamentarians, the private sector, and those that are elected. So the faith leaders speak truth to power by bringing closer information to those that decide. In addition, the faith leaders with their network, they have this good platform where they can work with communities in addressing challenges for malaria. We have good example of faith leaders in the HIV circles where they have provided platforms to Ministry of Health where testing and treatment is done at a church and the community members are able to accept the intervention. So this is an innovation working with faith leaders now in the malaria sector, where faith leaders are championing malaria at all the levels, at national level, at community level, even in their churches where they work. And the faith leaders are also given platforms by the Ministry of Health, understanding the vast network and reach in terms of the people and the communities that they reach. Because where there is a government, sometimes the government will end at the municipal, but the faith leaders are in the far, far rich communities where they can reach more people than the health facilities. And now the Ministry of Health has taken up this innovation to work with the faith leaders. And I believe the civil society organization now can engage more of the faith leaders so that we can have the maximum impact, which the Ministry of Health in the case of Zambia has taken advantage of. I'll give an example. The faith leaders in support of resource mobilization, they have given space to the Ministry of Health that can you train our members to be community health workers. They have also fundraised for malaria in various platforms, so just they can raise some funds to support the malaria program in areas where they have gaps. And they are the key people who dispel myths in the cases where we have seen community members using nets for fishing, community members using nets for other economic gain or selling. The faith leaders come in handy because they are respected both by the community and by those that decide in making decisions. So faith leaders are a key innovation, and every civil society organization should think about them and should think about what impact they would make. And in Africa, I think a large following. I submit. Thank you.
Wow, thanks to Flame Zambia for sharing with us these very concrete examples. And we also want to welcome all participants and all partners and all members that are still joining us for this forum, while we ask the two last questions. First to Mrs. Emily Katarikawe. what can civil society do to work with local and community-based organizations to ensure that everyone has equitable access to malaria treatment and malaria prevention tools?
Thank you very much, Segolene, and greetings to all of you who are participating in this World Malaria Day event. I think for us as civil society, we need to know the very basic, simple thing, that malaria is a result of a mosquito bite. Just preventing that bite would prevent malaria. But we know that many times it fails, and when it fails, being able to have proper diagnosis, either using a microscope or a rapid diagnostic kit, is very critical. And subsequent to that, having proper treatment for malaria, the right medicine and in the right doses, is very important. The key challenges with communities that we work with and what we need to bring to the fore for these community members to know is that many times the risk perception is very low. We've been with malaria for a long time and people don't think it will kill them. And that's why we've continued to lose lives, because the risk perception is very low. Secondly, we need to enable our communities understand that it is important for them to embrace vector control mechanisms or solutions. Using insecticide-treated mosquito nets is one thing that we need to communicate. Embracing and accepting indoor residue spraying. I don't know about other countries, but in Uganda, there is a bit of resistance to that. And also larviciding of the sources or breeding grounds of malaria. Those are important actions that civil society needs to push for people to understand the basics of malaria. However, we have poor health-seeking behaviors in our communities because people don't think it's very important to go as quickly as possible to health facilities. So we end up with people reporting late, and even accessing of the right treatment and adherence becomes a problem. We've had situations where family members share one dose of malaria because just one of them is lazy to go to the health facility. And the reality is, you talk about marginalized communities. The marginalized communities are actually the poor in our society. Malaria itself causes poverty because you spend a lot to treat just one bout of malaria. Secondly, malaria also can result into poverty because the resources you have, you're spending on treatment. We also know that the female mosquito is actually attractive to bird odor, which is also associated with poverty, lack of soap and to bathe, and the whole personal hygiene practice is more pronounced among the poor. So what can civil society do to mobilize resources? And in this, I'm talking about resources in terms of time, in terms of human resource, and in terms of finance. First of all, in terms of time, civil society must harness the time available to our community members and use them as change agents in their families, in their households, to talk about malaria. Nothing stops us from creating household champions against malaria. Two, in terms of resources, there are multiple resources in communities. Many of us in Africa, we can talk about retired nurses, retired teachers, who can be resourceful persons in the community that we can tap into. But there are also resources within our community that we know can repair mosquitoes. We know the mosquito repellent plants and how many households are actually planting those repellent plants around their households. We also know that there are systems in the communities, community-based organizations, social groups for finance, for savings scheme that can be used to champion the cause of malaria as key resource persons within the community. That aside, they are philanthropists in our communities. Every country you talk to, there is this one person who is rich and ready to put resources on the table to care for other people. Let's lobby them with evidence. Let's lobby them, show the impact of malaria on their neighbors and households.
Thank you so much, Emily, for your thoughts. The last question goes to Cecilia Seno. Mrs. Cecilia, how do you think we can engage youth in this fight? How do you think we can inspire them?
Young people are one of the demographics mostly affected by malaria. Therefore, using them in malaria prevention and elimination is the right way to go. For us to eliminate malaria by 2030, this is the time we bring in all people. Young people spend half of their time on technology, on phone, on communication. We have to tap into this as civil society organizations. They are mostly on social media. They do a lot of communication and a lot of things on technology. On social media, you will find young people with so many followers on TikTok, Twitter, Facebook, WhatsApp. We can develop our simple malaria prevention messages, sensitize them and train them for them to reach out to their peers on malaria elimination and prevention. It's also important we build the capacity of young people and ensure that they participate actively on policy table for malaria prevention and elimination. Young people are available, they have a lot of time on their sides. And the moment you start using them on technology, they run with it. Within a short time, they can reach out to their peers. And they believe, they trust themselves. And so we, civil society organizations in malaria, CS4ME members, must also start using young people. One way to get them on board is also looking at innovation. We can use football gala with the messages on malaria. Once we bring them together, we mobilize them, we use football to reach out to them on malaria prevention and elimination. They are there, they have time, and they cherish innovation. This is the time to use them. And I believe using them will reach out to their peers, will help us reach more people than ever. This is the time to use young people. They are available, they have capacity, they have time on their side to support malaria elimination. It is time, CS4ME and other civil society organizations and partners use young people to sustain their interest in malaria prevention and elimination. Thank you.
Thank you, Cecilia. Thank you so much. I think the key takeaway from this discussion is that we civil society have a very, very important and key role to play in working with leaders so that we can mobilize more domestic resources for the fight against malaria. And the key word here is domestic. We, our countries, need to take action as nations. We are now heading towards the end of this second part.
Cecilia from Ghana. Thank you very much. Babacar Cham from Senegal. Zenabu Ide from Cameroon and Niger, and Amu Butenga from Zambia, Flame, and Emily from Uganda. Thank you very much. Thank you for this great panel. We were able to learn a lot of things and very much a lot of argument as of why we need to invest to accelerate malaria. As you say, Emily, malaria can cause poverty, and we have seen that. We are seeing that in our community. So it's very important to ensure that our leaders can invest the domestic funding for malaria. And Cecilia, you spoke about the youth. And it's important to get the youth engaged. So we are calling on all the youth who are listening to us that next year we want a panel of young people and youth talking about their action in malaria and how they can be supported. Tina spoke about the private sector. We definitely need the private sector to invest more in malaria domestically and to also support the work of community health workers and civil society around malaria. And thank you very much. Thank you. Thank you. Really want to clap our hands for this great panel. Thank you very much. So we are going to show you a short video, nice video of other voices of civil society. And then we're going to take a 10-minute break. So 10-minute healthy break before we get into the last phase of our forum. So during the break, please do check again your internet connections, grab some water, anything that you would like. We hope that during this webinar, you are learning from the experience of our great speakers and CSOs, and you are also suggesting a lot of recommendations that should be done if you want to deliver zero malaria. So we are capturing all your comments on the chat, and we look forward to continue to have those discussions. So after the break, come back because we're going to have a series of great presentation from l'Initiative. You have Dr. Jeanne Dove with us, she's going to talk about malaria chemo prevention seasonal campaign, and probably something very interesting for communities and civil society. And we also have WHO, who will come back with Dr. Rob Alistair from the Global Malaria Program. He's going to talk to us about Reach the Unreached. We have Professor Charles Wanji from CRIB in Cameroon. He's doing an amazing work in research in malaria, and he's going to talk to us, civil society, about resistance. As you know, resistance to artemisinin is a great challenge right now in the fight against malaria. We also have Dr. Albert from GRC, from Sandru, which is a large local civil society organization, and he's going to talk to us about community health workers. We have also Hamza from Niger, Dr. Lynch. She's going to talk to us, Shanwan, she's going to talk to us about monoclonal antibodies. It's very interesting actually in terms of innovation, and she's coming from Georgetown University. And then we'll end with our last panel of civil society organization and closing remarks from Dr. Maxine, who will be joining us from Australia. So we look forward for this session, and right after the video, we're going to take a 10-minute break, and we'll see you soon for the last part of the forum. Thank you. you. Thank you to the CSOs who are taking part of our Reach the Unreached campaign, the Liver Zero Malaria Reach the Unreached. We're gonna drop the information in the chat if you want to participate in this campaign for the whole month of April. Is to change your profile picture and send a key message to one of your leaders. So thank you so much. We're gonna take a break. We'll come back in 10 minutes exactly, and we will start the last part of our forum. Thank you so much.